Good afternoon, everyone, and welcome to the new and enhanced TxRx Medications for Substance Use Disorder, ECHO, brought to you by the Center for Substance Use Training and Telementoring CSTAT by Beeville, Texas, in collaboration with UT Health San Antonio ECHO. For those who are new to ECHO, welcome. And I see some of the familiar faces back here. Welcome back. My name is Shreya Prasanna, and I will be facilitating today's discussion. Some housekeeping before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. If you are one of our Beeville, Texas providers, please make sure that you identify yourselves during this session. Please stay muted unless you're speaking, and we do encourage you to speak. Your mute button is on the bottom left of your Zoom controls. We encourage using the chat or raise your hand feature to pose questions or share perspectives. There are a lot of us in this space, so please keep your comments brief to allow others a chance to speak up. If you are having connection issues, please privately chat Taylor, our ECHO IT, for assistance. If you'd like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. We encourage everyone to join by video, especially for the discussion portion of the session. That said, regardless of how you've joined up here today, we are just as happy you're here to learn alongside us. We are recording these sessions for later distribution on our website. Any information you put in the chat will not be shared in the recording. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, birthdays, or any information that can easily identify an individual. For those who may be new to ECHO, it stands for Extension for Community Healthcare Outcomes. This is a model of lifelong learning and guided practice that connects community-based professionals with each other and a multidisciplinary team of subject matter experts to create a community of practice and learning. This model was developed by a liver specialist 21 years ago to support primary care physicians in delivering life-saving on-site treatment for hepatitis C virus to uninsured or underserved patients. By doing so, we move knowledge, not people, and improve access, enhance workforce capacity, and transform community health. While this model has its origins in healthcare, it is rapidly expanding to multiple areas such as education and civics. ECHO sessions typically begin with introductions of the team, followed by a brief 15 to 20-minute didactic related to medications for substance use. Next, a member of our learning community will be presenting a case with an emphasis on their questions, and then we move on to the discussion. The case is the core of these sessions. It is intrinsic to the all teach, all learn model of ECHO and the space for you to share your challenges, strategies, and resources with your learning community. ECHOs thrive on conversations that acknowledge and include all the perspectives. So we welcome your questions and your experiences in all our discussions. Remember, we're all learners and all teachers in this space, so your contribution matters. This session will end with a summary of key recommendations by the lead specialist. At the end of the session, the ECHO team will send out a post-session survey link that we kindly ask you to complete, as it gives us your feedback on how to refine these sessions to better address your priorities. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. I will now request Dr. Adrienne Lindsay, Director of CSTAT, to provide us a quick overview of this new program. Dr. Lindsay?
Thanks, Shreya. Welcome, everyone. Excited to see everyone here. As Shreya mentioned, I'm seeing some familiar faces, and I know we have some new learners as well. So this is really our TxRx ECHO 2.0, and for those of you that have been in some of our other learning communities, we've also merged with Shout, our hospital-facing ECHO program, to bring you this new program. So we have a new platform, as you all probably notice, and you're all here, so that's a good sign. It looks like everyone made it in okay, and hopefully some other folks will be joining us. And in the new iECHO platform, you'll be able to find all of your ECHO programs that you belong to, including, from spaces outside of UT Health. I wanted to mention a few things about the new program. One is our primary goal, which is really to address the shortage of prescribers treating substance use disorders with medication. So of course, we'll have a lot of prescribers here and then lots of members of their care teams here as well. You'll notice if you were in our previous program that this kind of reboot is a little more, the curricula is a little more linear and a little more modular. So you'll notice we're starting out with some of the foundational material, and then we'll build up to the more advanced material over the course of the year. We also have some new experts joining us, and they'll introduce themselves, but we're excited to have some new experts in stimulant use disorder and adolescent addiction medicine. And I know we've been hearing from a lot of you in the community that these two areas are a big need. And we also will meet the criteria for the DEA training requirements. So if you're needing those 8 required hours, each hour that you spend with us will count towards those hours. So you'll just want to keep those CE certificates. So I don't want to take up too much time. I know we have a lot to cover today. I will turn it over to Dr. Chowdhury, one of our new experts.
Thank you so much, Dr. Lindsay. Hello, everyone. My name is Dr. Chaudhry, and you can call me Ali. My background is in family medicine, and I train in adolescent addiction medicine at Boston Children's Hospital, Harvard Medical School in Massachusetts. And I have recently joined UT Health San Antonio to establish an adolescent addiction medicine program here that's supposed to be multifaceted, which includes medical management, psychiatric care, therapy, group therapy, and parental support. As we establish this program, we're trying to find collaborators across the state that can provide like the full continuum of care to our adolescent and young adult population. And I am very happy to join this ECHO, and hopefully I can contribute constructively somehow to this ECHO.
Thank you
Thank
so
you.
much, Dr. Chaudhary, for joining us today. Dr. Kowalczyk, if you could please introduce yourself.
Sure. I'm Alicia, Dr. Kowalczyk. I'm with Baylor College of Medicine here in Houston, Texas, in the Department of Family and Community Medicine. I'm boarded in addiction and family medicine, and I work with several of our community programs here in the greater Houston area that provide SUD treatment and prevention services, including Santa Maria Hostel, the Houston Recovery Center and their Sobering Center, and the SBIRT program for our county hospital system, Harris Health. Thank you.
Thank you so much for joining us. Dr. Shorter.
Good afternoon, everyone. I'm Daryl Shorter, board certified in both addiction psychiatry and general psychiatry. I'm also at Baylor College of Medicine with Dr. Kowalczyk. I oversee the Baylor Addiction Psychiatry Fellowship, and I'm also the medical director of addiction services here at the Menninger Clinic. Thanks for having me.
Thank you so much. Dr. Walker.
Good afternoon, everybody. I'm Crystal Walker. I'm a doctorally trained PA. So my students call me Dr. Walker, my patients call me PA Walker, and my friends call me Crystal. I will answer to all of them. I am currently at MHMR of Tarrant County, which is based in Fort Worth, Texas. And I'm currently the director of the Substance Use Disorders Medical and Clinical Services. We have a really robust substance use treatment department that has almost all of the ASAM levels of treatment, from residential with medically managed withdrawal to intensive outpatient to OBOT, supportive outpatient, intensive clinically managed residential. Really lucky to have a robust substance use treatment center here in Fort Worth, and happy to be here.
Thank you so much. And with that, Dr. Walker, you can take it away for your didactics.
Oh,
Whenever you're ready.
Sounds good. Okay. All right. So as Dr. Lindsay had mentioned, we are going to start off with some basics today. So I'm going to talk just a quick introduction to medications for substance use disorder. And I've already introduced myself, so I don't have any disclosures, no financial relationships. And of course, when I express an opinion, that's my own opinion. Here are some learning objectives that we're going to go through today. And just to give you a visual representation of what Dr. Lindsay was talking about, today is the start of our new ECHO series. And you can see here how the curriculum is divided up. We're going to have sections that focus on certain things in a linear fashion. So what we're going to start with is this introduction to medications. Today is going to be a brief overview. We have a really robust audience in these ECHO sessions. So we have peers, LCDCs, social workers, case managers, some administration, physicians, APPs, LVNs, RNs. We have such a diverse group that we're going to reset, set up a foundation so that we can have a common place to start when we start diving into the details of the nitty-gritty of treatment for all of these different variations of substance use disorders. So let's start with some definitions, okay? I want to talk about evidence-based practice, also known as evidence-based treatment, evidence-based medicine. You will see them abbreviated EBP, EBT, EBM. And essentially what this is there's three main pillars. You're going to take the best relevant research evidence, combine that with the client's values and preferences, and then sprinkle in the clinical expertise of the practitioner treating that individual. And all of that together makes evidence-based practice. So, the purpose of conducting research is to generate new knowledge or to validate an existing knowledge based on a theory. So if someone thinks that something is working, or you hear anecdotal evidence that this may work, oftentimes those things are going to be studied to validate that that is a true statement, that that is a true theory. Now, in contrast with just pure research, the purpose of evidence-based practice is about developing that new knowledge or that validation of that existing knowledge and translating that evidence and applying it to clinical practice. So just reading an article about the treatment of substance use or about opiate use disorder isn't always enough to immediately start treating a client or a patient. We need to incorporate that into clinical practice, into decision making. And that really is the purpose of evidence-based practice. Now, there is a fourth pillar to this, which is current clinical circumstances of the client. And it's not always found in a lot of the publications talking about the three pillars of evidence-based practice, but I personally really think this is a very valuable thing to consider in the realm of treating substance use disorder. Because where that patient is, are they in a residential service? Are they in a medically managed inpatient unit? Or are they in outpatient? This may alter what medications are available or the different types of approaches that you're going to take with treating that patient. So this is also a pillar that is important to consider when you're gathering information and trying to apply evidence-based practices. Now, why is evidence-based practice important? Well, it's been important for a very long time, but the advent of social media has made it even more crucial because so many things are advertised as quick fixes, miracle cures, and this is just a handful of things that I gathered from some social media posts. Talking about, cure everything from your arthritis to your anxiety to your depression with 30 days of kratom. Or, you know what? Cannabis oil cured my cancer. And one that was incredibly disturbing to me that was recently put out on social media was that putting a little sprinkle of borax laundry detergent in your water in the morning will cure your arthritis and do something with your stem cells. So this is why evidence-based practice is so important and really diving into research and clinical expertise. And are these things legitimate? Because oftentimes when things are too good to be true, taking a teaspoon of cannabis oil is going to cure your cancer, most often it is too good to be true. So applying evidence-based practices and verifying these items that we tell our patients and treatments that we recommend is incredibly important. Now, when we're talking about evidence-based practices, there is a component that we need to look at when we're talking specifically about medications and prescribing medications. And this is FDA-approved medication. So a medication, a drug, or a biological product that is determined to be safe and effective. Now, here's the caveats: for a specific use in a specific condition for a specific disorder. So the FDA is implementing evidence-based practices. They're gathering information. They're, conducting evaluations on the research that's out there. Often they'll have clinical expert panels discussing this before a medication is approved for a specific use in a specific condition. Now, just because a medication is FDA approved with all of these caveats doesn't mean that it's not used for other items. That's where that clinical expertise can come in sometimes. This is referred to as off-label drug use, off-label use. You can hear that pretty often in the realm of substance use. We talk about these items a lot because sometimes research lags behind. We are presented with all of these new issues. We will have a new drug pop up. It seems like every month that there's a lot of creativity out there and the research isn't always getting caught up. So we're often having to go with clinical expertise to find treatments and modalities to treat these individuals. So off-label can refer to a lot of things. So if you use a medication for a different medical condition. So one that a lot of people have heard about is probably Ozempic, right? Ozempic is approved for the treatment of diabetes, but a lot of people are using it for weight loss. Technically, that brand name Ozempic has not been approved for weight loss. So that's an off-label use of that medication. We can also do things in a different vehicle. So using a medication called buprenorphine is approved for the treatment of opiate use disorder, but only in certain vehicles, which we will talk about. But there is one called a patch, a Butrans patch is the brand name of it. This isn't approved for the treatment of opiate use disorder, therefore that would be an off-label use. So there's all sorts of caveats that come into the nitty-gritty about what a medication is FDA approved for. All right, so let's talk about some definitions. Again, this is getting us all on the same page, same baseline. So an over-the-counter medication is something that can be purchased without a prescription. We've all heard that naloxone, which is a nasal rescue medication, has been approved for over-the-counter, which means you do not need a prescription for this. You can go into a pharmacy and wherever it is sold and purchase this medication to reverse an opioid overdose. Let's also talk about dangerous drugs. So as a PA, this term is near and dear to my heart. So any APPs on the call, I want you to double check your TMB, your Texas Medical Board supervision, because any supervising physician that goes in and they have to click, is this APP allowed to prescribe dangerous drugs and are they allowed to prescribe controlled substances? Well, the state of Texas flip the script on a lot of people, and they are calling legend medications dangerous drugs. That is their definition of these substances. So frequently, supervising physicians will choose not to click dangerous drugs because in their mind, that means something completely different. So be aware that in the state of Texas, anything that requires a prescription, an antibiotic, an antihypertensive, those are labeled as dangerous drugs. And then we have our controlled substances. These are scheduled anywhere from 1 to 5. 1 is not used in medicine. It is banned from medical practice. Now, Schedule 2 are high potential for abuse, but there could be some potentials to it, so it can be prescribed, but is very highly regulated. And then Schedules 3, 4, and 5 have a lower potential, relative to Schedule 2, and so they tend to have their own regulations separate from the Schedule 2. So a Schedule 2 example would be methadone. A Schedule 3 example would be buprenorphine. Okay, let's dive into specific delivery of treatments in substance use settings. One definition that we need to get on the same page with is what's colloquially referred to as methadone clinics. Technically, these are called narcotic treatment programs or opiate treatment programs, NTPs, OTPs. These are federally regulated locations that are allowed to prescribe methadone for the treatment of opiate use disorder. This is the main purveyor of prescribing methadone for opiate use disorder. There are a lot of restrictions regarding that. And so this is the main location. Now, there are exceptions that we're likely going to get into in the next lecture series, but essentially, this is where this medication is limited to. And this is one of a barrier to receiving that treatment. We also need to talk about, in the world of substance use, something that's medically managed versus clinically managed. So I come from primary care. When I first started substance use treatment and people were talking about, oh, they're clinical, oh, this is clinically managed, I did not realize that that did not mean medical, because in my eyes, clinic means a medical facility. Oh, they're going to a clinic, they're seeing a provider. Well, in reality, according to ASAM and in the world of substance use, clinically managed often refers to those psychosocial wraparound services and receiving counseling, receiving psychoeducation, group therapy, etc. Whereas medically managed is very specific regarding medications and prescribers. Now, additionally to that, we have medically managed withdrawal and medically managed maintenance for many substance use treatments. And those can be different and include different medications for different substance use disorders. So speaking a little bit about the ASAM continuum of care, this is a great layout of the different types of levels of care that substance use can be addressed in. And you can see medically managed inpatient, medically managed residential versus clinically managed residential. And so those are what those terms are referring to. All right, let's jump into a very quick overview of our medications. Let's get this foundation set up for our next sessions. So let's look at opiate use disorder. Now, again, on November 14th, 2024, there's going to be a robust didactic diving into opiate use disorder. But on a surface level, there are 3 FDA-approved medications for the treatment of opiate use disorder: methadone, buprenorphine, and naltrexone. I do want to discuss 2 terms that are often associated with opiate use disorder: medication-assisted treatment, MAT treatment, and medications for opiate use disorder, sometimes pronounced mood. Everyone in my facility calls it MOD, but it just depends on who you're talking to. The advent of the term medication opiate use disorder came from an attempt to destigmatize the term assisted, as well as clarify what we were talking about. But what I have found is both of these terms are still robustly used in the substance use world. And what has happened in my facility is that MAT has become synonymous with an OTP. So if someone is getting referred to MAT services, they are going to be referred to an opiate treatment program or methadone maintenance treatment. So just be aware that these terms do exist, and always try to use clarifying language when possible to eliminate any confusion. And then, of course, we have some alternative evidence-based psychosocial interventions that work for opiate use disorder. Contingency management, for those of you who don't know, this is a type of behavioral therapy that uses reinforcement, often viewed as rewards for positive behavioral change. So this could consist of providing a voucher in exchange for attending all of your appointments or negative urine drug screens, and giving that positive feedback loop rewards to encourage and maintain treatment modalities. Then we have motivational interviewing, which we are going to have a robust session on July 24th, 2025. So if that's an interest to you and you want to learn more, definitely tune back in. And then peer support is also a really good tool in most substance use treatments. And if you want to learn more about that, there is a recovery science echo provided by Be Well and CSTAT that happens on the third Wednesday of every month. So a little bit more about the medications for opiate use disorder, but just a tiny bit, because you're going to get a lot more next session, is that there are various medications, vehicles, the way they're prescribed for the treatment of opiate use disorder. So you have buprenorphine monotherapy that comes in sublingual tablets, and you have extended release subcutaneous injections. Then you have buprenorphine naloxone combo medications that come in sublingual films and sublingual tablets. So we also have methadone, typically comes in two versions, tablets that are meant for oral suspension and an oral concentrate. Then we also have naltrexone, which is available in an extended release injectable. Now, of note, when we get to our next slide, notice that it's FDA approved for just the injectable version when it comes to opiate use disorder. But when we look at alcohol use disorder, naltrexone is also FDA approved, but in both an oral and an injectable version. There's also two other medications approved for alcohol use disorder, disulfiram and acamprosate. Now, anytime I talk to my patients about starting medications for alcohol use disorder, almost every patient universally thinks that it's antabuse or disulfiram. Oh, it's the medicine that's going to make me sick. It's been around for a long time and it's very well known. So taking a lot of time to educate the patient about the options and taking that pillar, right, that clinical expertise combined with patient preference, patient circumstances, and explaining each medication is going to be important with all of these treatments. And again, we also have our evidence-based psychosocial interventions. Now, stimulant use disorder. I am particularly excited about the next session coming up on this, especially with our new hub member. That's going to occur January 23rd, 2025. Now, currently, there is no FDA-approved medications, but there are a lot of research, a lot of effort being put into make this a more robust area where we do have more evidence-based options and more FDA-approved options for these conditions. Right now, the biggest ones that are available are psychosocial interventions in the way of contingency management and cognitive behavioral therapy. And then also quickly touch base on nicotine use disorder. There are 5 different versions of nicotine replacement therapy that are out there. We have prescription only, so these are in the forms of inhalers and nasal sprays, and then over the counter. So we have transdermal patches, gums, and lozenges. We also have non-nicotine legend, aka prescription only medications in bupropion and varenicline. And we will be learning more about the nitty-gritty of these treatment options on January 23rd. A quick touch base on some psychosocial interventions. One thing that's unique to nicotine use disorder is the 3-step model and the 5 A's. So the 3-step model is ask all patients about tobacco use, advise all patients who smoke to stop tobacco use, and either refer or connect them to resources to sustain their treatment. So that's the 3-step approach. And then the 5 A's is asking about tobacco use, advising on quitting, assess readiness to quit, and then assist the smokers that are ready to quit, and then arrange follow-ups. So, like I said, this was just a little amuse-bouche, a little taste, a little foundation laying to get us ready for all of our next sessions. So it was a pleasure, and I will have any questions if there are any.
Thank you so much, Dr. Walker, for this wonderful introduction and setting a nice foundation for us to get started in this series now. We may have time for maybe a question or two before we move on. We have a super quiet audience today, but we will move on and hopefully we'll get some questions in the chat as we continue to the next portion of our session. Thank you again, Dr. Walker. And thank you again for bringing this to us. With that, Taylor, if we can please move on to some announcements from the BVEL program. We are offering CME credits for these sessions. For this, you need to do 2 steps. First, you need to create a registered account. If you have not registered, please text your email address to 844-502-1338. And to claim CME, please text attend 100-97972 to the same number. You need to create the account only once. Next slide, please. Do you have a difficult case that you or your team have encountered? CSAT gives you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and the broader learning community. There is no need to prepare a formal presentation. We will provide a case form to fill out to help assist with your case presentation. Please email us at cstat.yudhiska.edu. Next slide, please. And do join us for our next session on November 14th. We will be speaking about use of medications for opioid use disorder. And with that, we will move on to our case. Dr. Marambagi, could you please introduce yourself and share the case whenever you're ready?
Yeah, sure. Hi, can you hear me well?
Yes.
Yeah, I'm Dr. Kapilan Marambage. I'm an addiction psychiatrist. I am an associate professor at UT Southwestern, and I'm the medical director for addiction psychiatry at Parkland Hospital. And I want to present a case today, which I will share the screen, and let me know if you can see the screen. Are you all able to see it now?
Yes.
Okay, wonderful.
Could
So,
you increase the size, click on the plus button to make it zoom in a bit so then we can see better.
okay, I don't know where the plus button is, but
Is right the zoom in button right at the top.
oh, oh, I got it. I'm sorry.
Yeah.
Is that better?
Yes, that's great. Thank you so much.
All right. So I am mainly running an inpatient consultation liaison addiction psychiatry service. So my team is mainly geared to see patients in the hospital setting. So we can carry out a lot of advanced kind of interventions for inpatient, but this patient is an outpatient, and I have a little outpatient operation also, where we have a clinic where patients can be brought in for inductions and also for so many other things that they can do follow-ups. It's like a bridge clinic. So this patient came to the clinic, and we wanted to hopefully get him off the fentanyl and start him on the buprenorphine. And then things didn't go as we liked, and then I'm going to explain why. So he's a 19-year-old Hispanic male, and what questions I have to get an answer from the experts would be to advise on buprenorphine induction for a fentanyl positive case. What is a reasonable washout period and induction protocol? And what is the best interim management strategy to ensure compliance? So if I were to explain, now we can do this in the inpatient setting without any problems. We have several different protocols we have used very successfully to induce patients who are coming off of fentanyl within a few hours, like 12 to 24 hours would be preferred from the last dose. In the inpatient setting, it's not a problem. So this patient we scheduled for an outpatient visit, And we expected that he will not have used fentanyl at least for 24 hours, preferably for 48 hours. So he came in and he gave us the history. And if I were to go to his substance use history, his main substance of abuse right now is opiates, and he has been using fentanyl for about 1 year. And he uses the M30 tablets, which are like the street preparation of fentanyl. And he uses about 10 of those tablets, which he snorts. And the last use at the time of encounter was less than 12 hours ago. Initially, when the nursing staff called him, he said he hadn't used in a couple of days. But when he eventually came to the clinic and when I started talking to him, he has actually used less than 12 hours ago the last fentanyl, and he did not have any opioid withdrawal symptoms. So his main problem is opioid use disorder. In addition to that, he also snorts cocaine, and he has given up on the cocaine, according to him, about 1 year ago. And we did a urine drug screen, and he didn't come positive for the cocaine, but he came positive for fentanyl. He smokes cannabis also about 2 blunts a day, so the urine drug screen was also positive for marijuana. So the urine drug screen was positive for fentanyl, positive for marijuana, negative for cocaine, negative for opiates, and no other drugs were found. He has used the last fentanyl about within the last 12 hours. So his diagnosis was opioid use disorder in the severe category. He has had multiple criteria to meet that. He has gone through withdrawals. He has had social issues, school issues, not finding a job, having family issues, and etc. Cannabis use disorder was moderate. It didn't have the 6 criteria, but it was somewhere there. Stimulant use disorder was also of the severe category, but it looked like it's in sustained remission. So he did not have any treatment in the past for substance use, no inpatient treatment, no counseling. He's just 19 years old. So he didn't have any of these in the past, no mutual groups. And so what at that point, because he wasn't going through withdrawals, his COW score was less than even 4. And we expect at least, 12-ish to, do an induction. And so he was way below that, and we didn't want to keep him for the next so many hours. It's not going to happen. We didn't think so because it was within 12 hours. What we did was we did a symptomatic treatment protocol, which we gave some clonidine. We gave a very few doses of clonazepam and some antiemetic medications like Sofran for him to go back with. The social history is Hispanic, lives with the family, lives with the mother. Mother is the one who brought him to the clinic. He doesn't have any children. He's unmarried. He has a girlfriend who is not substance user. And transportation is with the mother's car. Currently, he's housed and he's with the mom. He's unemployed. He has held some short-term employments recently, but he has gotten kind of unemployed recently. He denied any psychiatric history. He did not have anything on the PDMP. He wasn't on any medication at the time. He did not have any comorbid medical conditions. So the current treatment plan, as I explained earlier, was that we gave him symptomatic treatment for about 2 days and then asked him to refrain from using any more fentanyl and come back in about 2 days so that we can do the induction again. I mean, it was very unlucky that it was a Friday, so I had to ask him to come on Monday. Otherwise, I would have asked him to come the next day with symptomatic treatment. So he was given this medication. We scheduled the appointment for Monday. He did not show up on Monday. And when we called him, he said he used some fentanyl. And we rescheduled him again for the next Friday, gave him more of the symptomatic treatment to keep sober for that time. He didn't show again. So basically, we have lost this patient to, back into, we had a little opportunity that time, but we couldn't induce him because it was too soon. We didn't want to cause precipitated withdrawals in an outpatient clinic. And so we had to let him go. So my questions, if I were to ask you again, is what are your, inpatient, of course, we are quite expert at doing fentanyl inductions, even in the emergency room when in a hospital setting. But in an outpatient setting, which I'm sure you all have a lot of experience, for a fentanyl positive case, what's your approach? And what is a reasonable washout period? And what is the interim management strategy if you had to let the patient go and get him back on at another time when the patient is optimally ready for an induction? So those are the questions. I hope I didn't go over time. Shreya, am I okay?
No, you're perfect. Thank you so much, Dr. Marambage. This is a wonderful case that you brought to us. I'm going to open up the floor for any questions from our hub and our learning community.
Thank you so much for this case. I think it's really good points to explore and look at. So one of my questions for you is, does your clinic have any barriers or restrictions or hesitations to doing home inductions and sending the patient home with a buprenorphine prescription to manage that and start that on their own once they reach that level of withdrawal in order to start the medication? So is there any barriers to home induction with your clinic?
No, we don't have any barriers to home inductions, but this is a new clinic and we have a home induction protocol separately. We use the app and we do the whole thing. And like you said, that is the only option it looks like for this patient right now. But we really wanted to start the clinic inductions so that the staff gets familiar with it too. So you're right. We could have done a home induction maybe with this patient. We have a little reluctance when it comes to fentanyl users, whether we can time it perfectly on the app. But yes, we don't have any barriers to answer your question. We can do that with this patient, yes.
Thank you. I see some comments here on the chat from Dr. Kowalczyk. Yeah, Dr. Kowalczyk, if you would like to elaborate a bit.
Yeah, so there's some decent literature now out about either someone coming daily to clinic for observed dosing, microdosing starts, or at home induction with some education. Yeah, I just dropped one example protocol in the chart. There are others. It sounds like, it's a great idea to want to give your staff that experience and to meet the patient where they're at. Maybe this isn't the right patient to approach with that. I think it's really hard for patients to abstain from fentanyl for 24 hours on their own, even with a lot of support. I know before we had microinduction protocols and that literature out there, we really struggled even in a residential setting with 24-hour nursing and round-the-clock comfort meds to keep people from leaving before we could start the buprenorphine observed in that setting. And so, I think particularly for fentanyl, the at-home induction is something that I favor for that.
Yeah. Thank you.
But it can be patient specific. I think he's already told you this is not going to work for him and in clinic induction.
Yeah, we have microinduction protocols too, outpatient as well as inpatient Bernice method. We have 3 or 4 different methods where we use IV buprenorphine or Belbuca or Buitrans patches, or like the oral buprenorphine has been a challenge for us in the inpatient setting because our hospital does not allow splitting the pills and we don't have any compounding methods. But in the outpatient, we can do Bernice method microinductions. So that's a good way of going about either that or home induction. Yeah, I agree. But we have both in our clinic, yes. But as I said, I mean, I should have qualified that at the beginning. I really wanted to get this patient to be induced in the clinic so that we get used to that. But unfortunately, we couldn't execute that. So, but yeah, those alternatives are available.
Thank you. Tonya, I see your hand raised.
Hi, thanks a lot. This is a great presentation. I got a couple of questions. Was methadone ever on the table?
Yeah.
Maybe a referral to an OTP as opposed to an office setting. Was methadone ever considered because the induction could have happened that day with methadone. So was that ever an option?
Well, it is. We are going to make it an option right this moment. It is not because we don't have a pharmacy to be able to prescribe it over the weekend. We have the 3-day, 72-hour rule, which we could have done on a weekday. So that was my plan for Monday if he showed up and if it was still bad. But then we could have given him on a daily basis for about 3 days, whatever we could have induced with the methadone and then gone. But this patient also didn't want to go on methadone. That was another factor. He wanted to be on Suboxone regardless. But to answer your question, our clinic we are still going through some legal stuff to figure that out, to do methadone. But right now, we are planning on doing it through the pharmacy. And I'm very happy to ask you whether you have any more experience on that so that we can bring it in. But in our clinic, we can do within the 72 hours, we can dose methadone. But even that, we had to jump through a few hoops right now. So I cannot say it's ready right now, but I could have done it in a roundabout way and then send him to a methadone clinic if it was the week time, but the patient didn't want it.
Okay. The second question I had, because we're an OTP here in Houston, and a lot of times we will get those clients that they just cannot get the induction of bupe to happen. And so then methadone is the alternative. And that tends to be very helpful, at least getting them into the process, because then there can be a tapering from the methadone to the buprenorphine, but they're already sort of locked into services. So we've seen some success that way. But the second question I have is from a psychosocial perspective. He's 19. He lives with his mom. His mom drives him, which means his mom feeds him. His mom probably clothes him. His mom is very much engaged. My question is, was mom engaged in this process and taught what the options were so that she could best, because I guarantee you I can't guarantee you. What I've seen is that when we're dealing with these young people, when we engage the parent that is trying to engage that client, a lot of times they'll comply even with defiance, but they'll do so, and at least the process gets started. So my question is, was his mother engaged in this process at all, since she's so connected to him and basically how he moves about the world?
Very, very good point, actually. Thank you for bringing it up. This mom was in the room, but she was not involved in the whole discussion at all. She was the whole time kind of texting on her phone and not involved in it at all. She didn't want to consider which direction we were going. She didn't want to get involved in the conversation. Language barrier was a factor too, but we had a Spanish interpreter. But even then, she did not want to engage. And in fact, we wanted to reach out to her, but we have the 24 CFR Part 2 rules also, and I'm not quite sure whether we got the patient's consent to talk to the mother without him being present. But in any case, you are absolutely right. She was not involved, and that was a problem. Good point. Thank you.
Thank you so much. I see a comment here from Gary Latson. Has anyone on the panel have experience with the Boulder Quick Start method that Dr. Chaudhry mentioned earlier?
Yeah, I mentioned it, but I personally have not seen that happen, at least in Massachusetts.
Yeah, and I saw Dr. Kowalczyk, you had no experience either that you mentioned.
Looks really interesting though.
Yeah, basically the approach is that you put them into precipitated withdrawal, but then you you just give them the buprenorphine in the nick of time so that you can capture those withdrawal symptoms right away. And the pre-treatment kind of sort of is the thing that prevents that short window in which you are in fluoride withdrawal and the buprenorphine is not yet kicked in. Seems pretty daring, if I might say, but at the same time, I think it solves one of the problems, that's the problem of engagement early on in treatment, right? Especially with these fentanyl users, the issue is that it's very difficult if you lose them from the clinic like that day, that you won't have them again like in the clinic. The chances are they're not going to end up back in the clinic for a while then.
Yeah, I think, that's the lesson. I think you put exactly what you're saying is what happened that, I think the biggest lesson is that once you let them go, you will lose them, is what I feel. You have to come out with some plan, maybe either the methadone plan or the microinduction plan or the home induction plan, something like that is what I think I need to take away. Because symptomatic management definitely didn't work.
So,
Does anybody have experience?
I'm sorry.
Does anybody have experience with a higher dose buprenorphine
I think you're cutting off, so we could not
induction?
hear what you were saying.
I've seen described higher dose buprenorphine induction that basically risks all. That is okay.
Hi, Gary. We keep losing you. Would you be able to perhaps type your question or comment?
Yeah. Okay. Can I try again? Can you hear me now?
Yes.
Okay. So I've heard of doing buprenorphine induction before each withdrawal stage by doing a higher dose buprenorphine and being prepared to treat the precipitated withdrawal if it happens with even more higher dose buprenorphine. Does anybody have experience doing that? Basically just forging ahead and starting the induction anyway?
Yeah, we do that all the time in inpatient setting, but in the outpatient setting, that was a bit of a risk because a lot of these cases run into precipitated withdrawal. We do 16 milligrams followed by 8 milligrams after that. In the emergency room setting, some people have gone into bradyarrhythmias, so we don't want to take that chance. We have certain protocols lower than that, but I know what you mean, but that this setting was not the thing for that. So we didn't want to take that risk and kind of, run a risk of this patient running into any possible bad stuff. But we are familiar with those protocols too.
Thank you. Dr. Walker, you had some comments to share earlier.
Oh, yes, I was going to talk about one of your questions about trying to re-engage, trying to get them back into the clinic. I think that it's a pretty tall order to ask somebody to abstain from using fentanyl for 48 hours plus, and there could be a sense of failure on the client's behalf and that I can't do this, I'm not able to meet this clinic's requirements, I'm not going to come back because of some internalized stigma and not having the ability to do that. So I think re-engaging by having a staff member reach out, give reassurance, maybe give those options, let them know that something like once you figure out kind of if you want to do the home induction, micro induction, et cetera, to kind of explain that to try to re-engage, because there could definitely be a sense of failure on the client's part and then shame and stigma that comes along with that, preventing them from re-engaging.
That is so true. Yeah, we have peer navigators who reach out to the patients, but I have to admit that we haven't given all these, and the peer navigators are not kind of equipped to talk about all these medication options either. So, and then there was another part to this. I think this patient was not fully invested in this, I felt. Just the mother was pushing, maybe, although she didn't show the enthusiasm. So I have found that in young folks, and I'm sure you all have much more experience with this than me, but that was also a factor I felt. He's still partying, he doesn't want to give up the partying is what I felt. But true, we have to have a mechanism to reach out and communicate all those options. I agree.
Yeah, and I think one of the things that you have going for you, sorry to cut you off, Dr. Walker. One of the things that you have going for you is the mom came to the appointment, right? So I feel like she might not be engaged at that time, but that's you're into getting the patient back into the clinic. So if the patient, you can't reach the patient a couple of times, then perhaps you can reach out to the mom. Given he was okay, I don't know if he give explicit consent to having mom involved in care, but if he was okay in the first appointment, I would assume you at least got some initial consent sign, so you can reach out to the mom, and that might be your into getting the process rolling for getting him engaged again.
That's a good point. Yeah, maybe we should try and do that too. Yeah, that's true.
I just have one question about the history. Do you know what his experience with buprenorphine or Suboxone was prior to coming to the clinic?
It was slightly negative. He has done a preemptive induction, which I should have actually mentioned before. So he has used buprenorphine like 8 milligrams soon after, like without giving a good, washout period for the fentanyl, and had some precipitated withdrawal, which he self-treated back with fentanyl. So he has some negatives. Didn't go so bad, but not a positive experience. No, he had not been on it for a long time now. Street use.
Okay. I was just thinking about why or how it is that this patient had sort of made the decision in the room to agree to like this 48-hour period of washout with medications, and if there was more hope around the use of buprenorphine as a medication option, but it sounds like given the history, there may have been some additional fears or concerns about even getting started on the medication that would be an opportunity for additional conversation, psychoeducation, and to address that in the moment with the patient to really further reduce those fears and perhaps get a little bit more of the buy-in.
Yeah, actually, we did that part adequately, because when he said about the early thing, I said this is the exact reason why I don't want to induce you now, and that's why I want to give it a little time, and because there should be a gap. All that we did, but I don't know how much of it crossed his mind. I cannot be sure about that though.
We are getting close to time. I'll take one last question here, which is in the chat from Kerry. Has this client ever been involved with an outpatient treatment clinic?
No, this is the first time he came.
Thank you so much. With that, we will move on to our recommendations. Dr. Weems, we missed you earlier in the beginning of the session, so if you could please introduce yourself and please provide a summary of recommendations for today's session.
Thanks, Trey. Can you just confirm you can hear me okay on your end?
Yes.
Great.
Yes.
Hey, everybody, I'm John Weems. I'm an internal medicine doc and addiction medicine doc here at Community Care, which is Travis County's largest federally qualified healthcare system. And I'm lucky to be part of our SHOUT crews. I'm a co-PI on the SHOUT program under Be Well Texas, supporting hospitals across Texas and implementing hospital-based opioid use disorder care. And I'm really excited for this TxRx session. I think Dr. Walker kicked us off with some really critical foundational concepts. And I'll start with one of those and sort of summarizing the recommendations. And that's this, the nice three circle Venn diagram between research and evidence, patients' values and preferences, and clinical experience. And where we're at right now in our drugs crisis is the research and evidence is trying to catch up with so much that our patients have been trying to teach us for a very long time about what has changed in this era of fentanyl and other high potency synthetic opioids. And in that setting of uncertainty and involving evolving scientific evidence, we really have an opportunity to hold up our patients' values and preferences and then share clinical experience with all of each other. And so I'm grateful for this community of practice. We are in an era of options, and I think that'd be the first take home. One sort of schema you can use to organize those mentally is to think about washout options to start buprenorphine and overlap options. They go by a ton of names. Nomenclature is an issue. The good news is we're going to have a great session with Nick Christian, who's at NIDA right now, who's going to go through different strategies, and we have some guidance documents on the SHOUT website that we can send links to. But Dr. Maramagay's team is doing really innovative work to bring options from the hospital, where it's really built out, to the outpatient world. And it's an exciting, evolving place to be. And so it's an era of options. Don't forget methadone. The tried and true works the best for a very long time. We can center our patients in choosing amongst those options. The second takeaway point and recommendation is sort of echoing a lot of points that came up around family and supports. So the good news is a lot of people have gotten better, and recovery is out there. And whether that's engaging the mom and engaging a peer recovery support specialist, there's wraparound that's involved when it comes to stabilization. There's the medical part with inducing buprenorphine, but also that wraparound. So that'd be the second take-home point. And the third one is another theme that kind of came out in the discussion around engagement. And this gets into the really fun and fulfilling stuff in addiction medicine, really seeing and trying to work through shame. and to share our clinical optimism, because as clinicians, we know people get better. And on the other side, things will be better for this young man and for most of the patients we see. And so dealing with hope and fear and sharing our optimism. And then another big one, which is re-engagement. So how especially us here in the outpatient world, how do we keep the door open and maintain a low threshold so patients like this know that they can come back and we can keep working through the options for stabilization? So those are the three take-homes. The first one is that we're in an era of options where we can hold up our patients' values and preferences. The wraparound, particularly values and supports, is a critical part of care, and thinking about engagement and re-engagement, because as clinicians, we know this work is fulfilling and fun, and people get better, and we're allowed to share that optimism with our patients.
Thank you so much, Dr. Beams, for this great summary. And thank you again, Dr. Marabage, for bringing this case to us so we could discuss it and have a great discussion around it. And thank you, Dr. Walker, for setting the stage for this ECHO series. And thank you all for joining this session today. As a reminder, to earn C credits, please text the activity code 1009-7972 to 844-502-1338 by midnight tonight. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@utisca.edu. We look forward to seeing you at our next session. Remember, we meet on every second Thursdays and second and fourth Thursdays of each month. I apologize. So we are seeing our next session will be on Thursday, November 14th. Have a wonderful rest of your day. Thank you.